Now we will be discussing the role of innovation in COVID-19 response, especially in the Indian healthcare settings. Today we will be talking about this very interesting topic with Dr. Soumyadeep Acharya, John Hopkins Center for Bioengineering, Innovation and Design. He was the chief architect of a new graduate program in bioengineering, innovation and design, and also runs a program in global medical technology innovation. Several of these innovations have received funding from USAID and other agencies and are in preliminary field studies in South Asia and East Africa. Welcome, Doctor. And then we have with us Neha Verma, co-founder and CEO of InTelehealth. She is an engineer and a serial entrepreneur, as she describes herself, with expertise in technology for global health. She is the co-founder and CEO of InTelehealth, a technology nonprofit that delivers health services where there are no doctors through telemedicine. She is a Rainer Arnhold Fellow and an Able Fellow. Welcome, Neha. I hand over to both of you now.
Well, thank you. Thank you, organizers, for the opportunity to speak about our work and more specifically what our organization has been doing for the COVID-19 response. Thank you for the introduction. I am the board president for InTelehealth, a tech nonprofit that is primarily doing telemedicine and digital health interventions globally. And Neha is the CEO and co-founder along with me. Next slide. Before we go any further, just a conflict of interest disclaimer. Neha, I am the board president, and my day job is as faculty at Johns Hopkins. And so this arrangement has been reviewed and approved by the Johns Hopkins University in accordance with its conflict of interest policies. So briefly about InTelehealth, before we go specifically into what we try to do for the COVID-19 response, InTelehealth, as I mentioned, is a tech nonprofit that has developed an open source telemedicine platform that connects frontline health workers like community health workers, nurses, and patients to remote doctors in the cloud. We assist NGOs, field partners, governments in implementing telemedicine projects. At the heart of our intervention really is this knowledge-enabled expert system, a very scalable, flexible, rapidly flexible, customizable expert system that allows a frontline health worker allows for task shifting of several things to a frontline health worker that otherwise carries with it an enormous burden of training. So for example, in one of our implementations in comprehensive primary care in Odisha, frontline health workers are able to take a comprehensive adaptive full medical history based on the presenting symptom of the patient, based on this, protocols that are in the expert system. In another implementation focused on child health in Philippines, the FHWs there are able to, adhere to very specific antenatal care protocols and guidelines, thanks to the protocols that are built into the platform, so on and so forth. We're also doing interventions in non-communicable diseases. So the kind of the spectrum of things that we were doing up until COVID happened ranged from comprehensive primary care assisted through frontline health workers in a telemedicine type of a platform, through very specific public health interventions such as antenatal screening services, non-communicable disease management, etc. Recently, we were also recognized by the World Economic Forum and Niti Aayog as an innovative platform to respond to the COVID-19 pandemic. And that's where I'd like to hand it over to Neha to talk specifically about what InTelehealth has been doing in response to the COVID-19 pandemic. Neha, what do you?
Thank you so much, Dr. Acharya. So, COVID-19 as I'm sure we've been hearing throughout the last 2 days and through our own experiences, has put a lot of strain on vulnerable communities such as the urban and rural poor. We were mainly working with rural poor communities, but also started working within urban communities during the pandemic. Some of the main problems we saw in the communities where we were working were that, even during as the pandemic happened, essential service workers, community health workers continued to work within these communities, and they were responding to the economic needs of these communities, like delivering food, water, housing, sanitation services. So community toilets still had to remain operational. Food banks were actually distributing foods, and both the organizations that were running these essential service delivery interventions, as well as the workers themselves, needed information on adequate control measures to ensure that they were staying safe, while also they were combating a lot of misinformation and mistrust within their communities. So they needed to also provide the beneficiaries with the right information. The other, echoing problem all over was that people living in these underserved communities, especially in rural areas more so than urban, faced a lot of difficulty in accessing even basic medical services. So a lot of medical care was disrupted. More women were giving birth at home because of fear of coming to a facility. Obviously, immunizations were being missed for children. If you were having a problem, it was very difficult for you to get to even a government primary health center if you were in a rural area. The health workers were also engaged in COVID activities, so OPDs were not running a lot of the times. So people living in these communities who did not have regular access to doctors before, even more so faced a lot of difficulty. In addition, as migrant workers were returning home to their villages, there was a lot of confusion and mistrust in these communities about what to do. And several migrant workers, as we've seen in the literature as well, were infected during their travels back. And then therefore there were outbreaks happening in these communities, but rural areas did not really have access to doctors, even pre-pandemic, regular access. And this just exacerbated some of the problems that they were already facing. So there was a critical need to make affordable quality medical services available to them in the interim while the health system was responding to the pandemic. We created, therefore, along with Arugya Foundation and the Nudge Center for Social Innovation, the COVID-19 Pandemic Wellbeing Task Force, collaborative of more than 20 nonprofits and tech companies. Right now, we are at 27 nonprofits and tech companies, some of whom include Goonj, Pratham, large NGOs that are otherwise involved in education, healthcare, other all kinds of issue areas, as well as technology partners like Infosys, Wipro, VideoWiki, and Noura Health. This collaboration of nonprofits came together. The implementation and community partners were mainly NGOs who worked on the ground to deliver services, essential services in communities. Together, the task force launched two initiatives. One was My Healthline, which was led by Arugya Foundation. It was an IVR helpline, a multilingual website, and a chatbot. The website was available in multiple languages, and was disseminated through the implementation partners. The IVR helpline was widely distributed in rural, IVR helpline website were widely distributed in rural and urban areas, and the chatbot was distributed over Facebook and over a website. And so people could come on to call the IVR, get routed through a list of questions to understand what their problems were, and again speak with a doctor. And with the chatbot, they were mainly chatting with telehealth educators who would provide them with the information they needed about COVID. And if this was a patient seeking medical services, would then arrange for a teleconsultation with a doctor. The specialties available included gynecology, general outpatient care, pediatrics, etc., and mental health. Along with that, the second initiative was IntelliSafe. This was an online training program with an app and website that was launched for essential service workers and health workers. So essential service workers are basically NGO workers who are going out and working at soup kitchens, food distribution, working in community toilets, and health workers, which were nurses, doctors, paramedics, and frontline workers. So there were e-learning modules that were launched in personal protection and infection control training. Along with that, there was Zoom on live training that would happen of a 2-hour duration to provide training to these frontline workers. So some of the articles you could check out on www.intellisafe.org. It includes articles that are more specific for health workers, such as proper donning and doffing of PPE, mask reuse guidelines, and there was also a connection with the COVID-19 info guide at Johns Hopkins, which was curating the best and available practical evidence in PPE reuse and extended use of PPE. The app was also made available with a WhatsApp chat for health workers to ask any questions about PPE use and PPE extended use. So the IVR helpline for My Healthline received about 10,000 calls. About 40% of these calls were for patients presenting with COVID-19 symptoms, 60% for other health issues. So 25% was for chronic health problems like hypertension or diabetes. 25% were for acute health issues, people facing gastrointestinal problems, gynecological issues, and about 10% of the calls were for mental health. The website that was launched along with the IVR had videos that were translated into 13 languages, including sign language, with various informational videos about COVID-19, and that received about 6,000 visitors. There was a self-assessment on the website where you could get a health risk assessment for yourself. 61% of visitors were low risk, 23% of visitors were moderate risk, and 16% were high risk. If you were high risk, the website did present you with where you could go to get tested, and also a link to call the IVR helpline so that you can get further information about your next steps. The chatbot received 98,000 interactions. However, these were from people of a higher economic stature. So even though the chatbot was distributed as well within low-income communities, which was our target group for this intervention, it was not really very well used within these communities. IVR was the most accessible option for them. On the IntelliSafe side, we conducted 43 online sessions for 222 NGOs operating in 22 states of India. So this program directly trained 1,438 participants. These participants then went out and trained their frontline staff. So these were supervisory level of members of the NGOs. They went out and trained 8,396 field staff and 53,585 community members and families. So that was they were indirectly trained by us through these participants. Of these participants, about 757 participated in a pre-post training quiz analysis. 80% of them scored 80% or more, and we also provided training to 160 doctors in the use of telemedicine. So it was interesting to see that even though we launched our online training and materials for both a health worker as well as for the essential workers, frontline NGO workers working not in health but in other kinds of services, the use was overwhelmingly more in workers in other sectors, working in food, sanitation, housing, as opposed to those working in healthcare. We hypothesized that the people working in the healthcare sector were already getting this information about personal safety from their own organizations, like the hospital group that they were affiliated with, whereas NGO workers were really not getting a lot of good quality information from anywhere. There was a lot of confusion in the participants during the training around mask use, what type of mask to use, how long to use it for, what does proper fit look like. There was mistrust because early on there were certain messages about not wearing masks, and then guidance was put out that you should be wearing cloth masks. So there was a lot of confusion among participants and a lack of trust about information that was being received. by them from other channels like the media or WhatsApp forward. So the question and answer sessions after these training sessions of the online training would sometimes last an hour long. Some of the other interesting questions that would pop up as, what do I do if I am a pregnant woman, or if a pregnant woman is coming to pick up food from my services, from my food kitchen. So there were a lot of interesting questions that aren't very well addressed currently by media that were cropping up in the training. So we did a independent samples t-test. Pre-training and post-training participants were sent a questionnaire about their level of knowledge about information about COVID, around questions like mask use, hand washing, social distancing practices, around disinfection of service of counters, because that was another skill that the NGO workers needed to have while they were delivering services. So pre-training, the mean knowledge of participants was 6.6, and post-training it was raised to 9.1, and that's a 38% confident they feel about the safety measures they're taking. And so a 5% increase in 5.5% increase in level of confidence. We asked them how informed they felt about COVID-19 infection prevention. So pre-training it was at 3.97, and post-training that raised up to 4.39. That was a 10.6% increase. And when asked, do you feel you're getting the correct information on prevention from COVID-19? Pre-training, it was at 4.13, and post-training that was raised to 4.43, an increase of 7.7%. And this is also an independent samples t-test with statistically significant change. So the lessons that we learned: the vulnerable communities are especially prone to COVID-19, and especially the most high-risk situations that the communities themselves were concerned about. So these NGO workers were typically people who attended the trainings, were typically people who lived in those slum areas or lived in that rural area. The most concerning situations for them were that they lived in crowded areas. Use of community toilets was another recurring theme and concern around how do you use it. It was difficult to keep soap at these community toilets because it would keep getting stolen. And so hand hygiene would be difficult for them to fully practice at community toilets. They also worked in informal service sectors, and they interacted with several people in a day. So a lot of these NGO workers in their day jobs were also rickshaw pullers, or they were working in daily wage laborers, or they were working as home help. So there was a lot of interactions that they had with several people in a day, and they weren't very clear about how to keep themselves safe. In rural areas, the biggest risk that communities felt were migrant workers coming back to their communities, and migrant workers themselves were concerned about the risk of exposure during their travel back, as well as the time they would spend in camps. There was several misinformation and myths that were circulating largely through WhatsApp forwards that was happening, and there were questions around mask use was the most confusing part for users. The other important part we observed was that trust was a crucial component in delivering health services to communities. So in communities where we distributed the IVR helpline through posters or through mass messaging campaigns, there was a lesser number of people calling in from those communities, as opposed to the places where the NGO workers who had been trained in IntelliSafe, who were distributing the My Healthline phone number. There was a much higher call rate to the IVR helpline. So telemedicine has been an important way that a lot of organizations are responding to the COVID-19 pandemic. But the way that a telehealth helpline is perceived by people is largely a component of the trust in the organization that is delivering the telehealth service. So can I trust this phone number or this app or this website where I have to go and get my healthcare services? So especially in these communities, trust was a crucial component. And so where we were able to address trust, we were able to see higher use among those populations. Same goes for providing health information via IntelliSafe. Our in-person trainings, where there was a higher level of trust, had greater number of participants. Our website and all of the video materials on there received about 20,000 visitors and page views. The services, therefore, that we were providing, we used trusted NGOs familiar to these communities. And that was another interesting learning for us, getting 27 NGOs and tech companies working together to disseminate and to co-create this intervention was, and to do so in a very short frame of time, required a lot of collaboration and coordination. The other important part is that the use of IVR and multiple language support is very important. As much as digital technology, use of Facebook, use of chatbots or WhatsApp has penetrated into the population, they may not have the technical capacity to use it. So IVR still remains the best way to have most population access of interactive voice response being just a phone call. And making sure that that is available in multiple languages is other extremely important. We worked with two organizations, VideoWiki and Handicap International, both of which provide rapid support to translate any content into multiple languages in a very quick and cost-effective way. Chatbots were less accessible and unfamiliar to our target population. It did receive use from a higher income population within urban areas. Data protection, privacy, and trust are important considerations. So with our COVID-19 risk assessment that we had on our website, we were not collecting geotag information. And even though that was shared with disclaimers in unofficial anecdotal interviews that we had with people, one of the biggest concerns that they had was, are you tracking my data? Are you going to let the government know that I am a high risk for COVID? Especially initially when the government was having very strict quarantine measures in place, and people were afraid of being outed of having COVID or having a high risk of COVID. So it's very important that data protection, privacy, and trust are addressed within developing of and delivering technology-based interventions. We worked with 3 tech companies, Infosys, Wipro, and Portal Frame, to build out and deploy technology resources. So, within a period of 2 to 3 weeks, we were able to deploy all the apps, website, and all of the technology required to scale and deliver the intervention very quickly. And this was delivered between, we started discussions in March. Both the IVR helpline as well as the IntelliSafe training went live in April and was operational through July, and the training in through August. And we used lean startup methods and design thinking to quickly roll out an MVP and then further refine. So one of the first things was looking at a health worker audience and an NGO worker audience, and then we saw that the NGO worker audience is really where the gaps are in information delivery, whereas health workers were being quite well served. So then we focused more on that audience. And collaboration and coordinated action were really the key to achieving these successes. Thank you so much. Dr. Acharya, over to you for any closing thoughts.
No, I think you said it all. Would welcome questions.
Thank you, Dr. Soumyadeep and Neha, for this insightful conversation on technology and use of innovation and how it can possibly impact behavior change in communities. Okay, so we can move on to questions now. We have a question from an anonymous user. Were there any specific diagnoses that were seen in the mental health calls?
Most of the calls were around anxiety, were just anxiety and people feeling isolated and not feeling anxiety because of COVID. So that would be the most predominant and overwhelmingly the most important type of call that was coming in.
Okay, we have a question from Saminda Kumara. How are you going to manage those points who are trying to find out by telemedicine? Those, I'm not sure what this means. I'll get back to you about that. We can move on to the next question. Do you have referral services if the patients required immediate hospital support?
Yes, so there were, and most of the calls that were coming in from to the IVR helpline were from Mumbai and Delhi, or from rural areas nearby. Now, the challenge with people calling in from urban centers, obviously they were referred if needed, but the challenge with populations calling in from rural centers, and a few calls especially stand out to me, were that where am I going to go get tested for COVID? So we had several migrant worker phone calls who were suspected COVID cases who needed to be referred for testing. And can you imagine the experience for them having to spend that much time traveling from an urban center, coming back home, only to be told you need to go back to this place to get tested? Because back then, that early in the pandemic, testing wasn't available in rural sub-district hospitals and district hospitals. Everything was concentrated in the urban areas. So I would say yes, that while we were making referrals, uh, it was it was hard to see how some of those referrals could even have been complied with if you were in a rural area.
Hmm. Yes. So now the question for Saminda Kumar: how are you going to manage those patients who are found out from by telemedicine?
I'm not sure I
I
fully
think
understand the question, but I can take a stab at what I thought I understood. So when someone would call in the helpline, they were first received by a case manager. The call was received by a case manager who would take their history and physical exam and some basic examinations. So like asking them, what do you know what your temperature is? Do you have a rash, or send me a picture of something if they were able to get to a smartphone. The case manager basically was guided through the algorithms in the InTelehealth application, so that they were able to collect a lot of detailed patient history. Then the case manager would forward the case to the right kind of doctor, whether it was a general physician, a gynecologist, a pediatrician, and the doctor would then call the patient back. So the patient would be told to hang on. They would get a call back from the doctor, and the two would have a discussion, and the doctor would provide a prescription with medications and a management plan that was sent back. The case manager would send the prescription via WhatsApp or via SMS, or in some cases just reading it out to the patient if they didn't have access to a device. So that's how the workflow would go for a teleconsult.
Hmm. Thank you. We have another question. Did you have referral services if the patients required immediate hospital support?
I would say that we actually didn't get any calls of patients calling for emergency services. I think patients themselves understood that this is a helpline for general healthcare as opposed to I need immediate medical assistance.
We have another question from an anonymous user. Was there any advertising done about the helpline?
Yes, we did put out posters. We were unable to run any kind of Facebook ads or Twitter ads or Google, because a lot of any ads with the term COVID or um, healthcare related were actually being blocked on these platforms in the early days of the pandemic, and it was difficult therefore to reach people. So I mean, there's an interesting thought in there about the role of big tech, which is what we rely on sometimes to reach people through digital means, and whether their response in the way, of course, big tech was making decisions to curb misinformation spread, but the other thing that it did was made dissemination of information even harder, and especially so for vulnerable communities. I mean, these communities were facing challenges even before the pandemic. There's the internet haves and have nots, right? So we did do offline advertising. I would say the most successful method of delivery for us was still in-person word of mouth. So the NGO workers sharing with their community members. So Pratham, for example, runs schools all over the country. So all of their teachers were sharing this information with their students and family members. There was Bacha, which is an NGO that works in most slums in Mumbai. Their girl health leaders were sharing these informations in bastis in Mumbai. So word of mouth actually was the best advertising. Well, even though we used multiple different advertising avenues, word of mouth had the highest ROI for the communities of interest for us.
Thank you. We have a question from Shobha Varthaman. She's asking, was the teleconsulting a paid service?
No, it was a free service.
Okay.
For the requests that were coming in from the chatbot, if people were from an affordable economic stature, they were given an option to make a donation to cover the cost of their consultation, as well as to cover the cost of a consultation for family in need.
Okay. We have one last question from Mr. Hussain. What are the strategies you have followed to reduce the social stigma on COVID-19 positive cases?
That's so the stigma was quite high in the early days of the pandemic. In our experience, it's lessened now, but in the very early days, the biggest concerns that we were hearing from all of the NGOs that we were working with is people hiding their status, not complying with quarantine, or concerns from the community that other people may be hiding their status, right? We did have a couple of videos up on the website, as well as that were disseminated on WhatsApp. These videos were translated into 13 different languages. This was a video that was actually put out by the World Health Organization, and a second video that was put out by the Ministry of Health and Family Welfare. So that was one way. Again, the most effective way was peer-to-peer education. So those 53,000 community leaders and families who were trained, as well as the 8,000 odd frontline NGO staff that were trained, were the best way for us to share information and disseminate information about COVID and reducing the stigma associated with it.
Okay. Thank you so much for your time, both Dr. Soumyadeep and Neha Verma. I'm sure a lot of lessons have been learned today after your session for all kinds of healthcare providers and how to reach out to the communities in a more effective way. Thank you so much for joining us today.
Thank you.